So if you join the ranks, we all nod knowingly that nobody actually ever wants to be in our specialty unless you are in our specialty.
Hello there, Jean.
Can you hear me?
I can. How are you?
I'm crazy busy right now, but I'm good.
Well, I appreciate you taking some time to hang out with me.
No, I'm always happy to hang out with you. It's just the rest of the day that I could do without.
Stupid patience, man. If they didn't have patience, being a doctor is so easy.
It's crazy because even before COVID started surging, and we haven't even actually picked up the traction I thought we would. But I'm not totally surprised because the vaccine, you have to have probably 3 times more cases before you overwhelm the hospital. But that being said, we had this insane surge in bread and butter. And I'm like, who are these people and what do they want?
Interesting.
Yeah, it is kind of weird. And it wasn't just me. I was like thinking, because, our summers here in Arizona for years now have been unusually high because most of those winter visitors will leave. But we're used to that. But this was weird. It was almost like when it rains a lot suddenly. Like, what is this? And it wasn't the post-COVID surge, those people that delayed care. It was really just people who suddenly got sick, and there was just so many of them. So I asked the other hospitalists, I said, have you seen this? And they actually hired like whole new teams to take care of that. And that was pre-surge. And I thought this is horrible because they were taking up an allotment of what we would have considered reserved beds. And so now we have less reserve and also less staff.
Interesting.
So I'm thinking,
you think it's just
a really
stress
good
related?
I don't know. I mean, it's like I said, bread and butter. So it was all comers, typical stuff. You just doubled your census. So I'm like, who are these people? But I don't know. I don't know why they did it because I've been here for 15 years and I haven't seen that kind of uptick, right? Yeah. Like usually there's something that there's a pattern or some sort of seasonal thing. But this was more like just, I don't know. There was just more people. It probably, you would see it if more people moved here. I think that's maybe what happened because we did have a big home thing happen with California coming.
Interesting.
So now we just got all of those guys here to create our population disease. Yeah, that's must. I was like, oh, why is this happening? But that makes so much more sense now. Yeah, it's just population increased.
Yeah. Well, we are live. I think you might have mistakenly went live before I got here. So we're hanging out with 273 people right now. Luckily, we didn't say anything bad. Like, oh, these students. No, just kidding. No. Terrible. But the patients. Oh, Lord, let me tell you about the patients. Well, I'm excited to chat with you. Can you do video tonight? Are you in between driving around to different dialysis centers? What's going on with you?
I don't mind doing video, but I am in my car because all I could do is just like leave the hospital and get in my car. Is that going to be a problem?
It's up to you.
I don't really care. It's not like see how I can do it here. Is there a button?
There should be a little next to your blue little microphone button. There should be a little weird looking camera circle thingy.
Oh, okay. That's what it is. Okay, there you go.
There it is.
Okay.
Hello.
Yeah, so you guys get to experience Arizona heat. This is what it looks like. It's all sticky and musty right now because of the monsoon.
There you go. Yeah. Well, I'm excited to chat with you and help some students really understand what's going on out there in the world of nephrology. This really nerdy specialty. I loved nerding out with you. Like, you got to be good at math. You got to like all the nuances and details. So I'm excited to chat with you and hope some people learn to like nephrology because it's an important one out there. Apparently peeing is important for you.
Yeah, no, peeing is great. But actually, this is really timely, and this is probably why I got really excited that you even asked, although you've been working on this for a while with different specialties. The nephrology fellowships didn't fill for years, and this is like the all-time low. And then of those that filled, the number of people that passed their boards was significantly different. So we're going to have like some sort of a huge vacuum that needs to be filled. with subspecialists pretty soon here. So if these students are kind of filling out the market or whatever, it's kind of nice to know that in about 5-10 years, you guys will be my nephrologist, let alone one of my colleagues, because it seems to be there's going to be like this gap of either I can't retire because nobody's around, or you guys fill them. So
nice. Well, hopefully we'll have 294 new nephrologists after this session. So one of the questions that the students love to hear about is, what is bread and butter, right? You talked about this surge of bread and butter stuff. So what is bread and butter nephrology?
Oh, okay. So, you've got your acute renal failure patients. And so nephrology practices are really interesting. Most of the nephrology practice in the nation have a combination of hospital, office, dialysis, right? And then of that, there's an interesting mashup. I used to think that it was pretty evenly spread, but in the nation, nephrologists can very well make their living off of acute renal failure because of how many times they can have a consult and how that pays out. But, you want continuity. Part of the attraction of nephrology is continuity. So bread and butter hospital is going to be your acute renal failure, your hyponatremia, your congestive heart failure with volume overload, your acid-base problems, your other electrolyte problems. So what was happening that I was telling you about the total influx was this combination of just people that hadn't really delayed care. They just got timely sick. And so it makes sense that there's just more people here. And so we got that percentage coming into the hospital with those problems.
Interesting. So nephrology, for those who are here who don't know what nephrology is, explain it, because it's not a specialty that people really think about when they think about going to medical school. You become an internist, you become a pediatrician, family practice doc.
It's bizarrely still mysterious to everyone, and that's part of the attraction, is that you join kind of a mysterious elite, and you think that mystery will go away, but it actually doesn't. It's bizarre. People refuse to learn about it because it just looks so intimidating or something. So I saw these t-shirts and anatomy boards. I don't know why it filled my feed, but to this day, you look at the anatomy, you look at the loop of Henle, you look at all the electrolytes, and you get overwhelmed by the idea that you've got to account for every single one of those things moving while creating something that then sustains something. And those kinds of cognitive skills, just people are like, I don't know, that's a little too complicated. And I don't know, you guys handle that. I'm going to go over here and do this kind of thing. So it creates this perpetual arena that you kind of, nobody will want any part of your territory. Not another subspecialist, not an internist. You're not threatened in any way. They just stay off your turf and give you plenty homage. So if you join the ranks, we all nod knowingly that nobody actually ever wants to be in our specialty unless you are in our specialty.
Is there a secret handshake that you all do?
Yeah. Did you see some of these TikToks? They're pretty funny about the devious nephrologist against the devious cardiologist.
No, I haven't seen those one. Is that Goman Flecken, whatever his name is?
Yeah.
Is he doing those ones?
Classic. Yeah,
he is hilarious.
I know. He's like my kindred, spirit when it comes to explaining how nephrologists get cranky on a bad day, right?
Yeah. So what are you doing day in and day out? Because I think one of the interesting things, having had you on the Specialty Stories podcast, was you travel a lot for your job in and around your area, right, going to dialysis centers and stuff. What does that look like?
Yeah, so a lot of nephrologists juggle, right? So since you have this continuity of care, you can probably start with an office-based practice. You get your referrals from outpatient physicians, or say their follow-ups from the hospital. But regardless, you have your outpatient office. You do that. You might mix it in during the day that you round at a hospital, or you might separate it. But you have that, and that tends to be patients who are stable enough to see you in the office, and then you have follow-up with them. And they may never be hospitalized. That would be nice. And a large majority of them never progress to dialysis, but they still need to optimize their prevention for preventing renal failure and kidney failure. And because kidney disease is so in the foreground, you do end up being like a super internist. Like you optimize their blood pressure, their diabetes. You look at all their meds. You're looking at other factors like kidney stones and gout, obstruction. So you're kind of in everyone's pot, trying to make sure that we get our piece right downstream. And then I'll travel to the hospital either before office, or maybe I'm lucky and I just have the hospital all day. So the hospital is really just your hospital follow-ups, and they could be your office patient or they could be new consults. And then I have very discrete days that I do dialysis, and dialysis is really kind of a unique subset, right? So historically, we would see them once a month, but then about 20 years ago, the government decided to pay less and have you do more, which I'm not opposed to seeing them more often. But quite frankly, dialysis patients are seen more than really any other patient from the time of inception, right? So once you're a dialysis patient, you're seen 3 times a week by a nurse and techs, and then typically 4 times a month by a nephrologist. But most patients will be seen once a month and then maybe an additional one time. But what I'm saying is the government took your one visit, divided it by 4, and paid you even less for it. So their idea was to accomplish more visits, but they did get in the we pay you less in general for it. So it's kind of funny, it's like numeric tricking. You get a certain amount for one visit, and then you get the same amount if you do 2 or 3, and then you get the rest of it if you did all 4. But things are so busy, most people can't see them 4 times, and the value of seeing them 4 times, unless they're unstable for some reason, is really not there, right? So most patients get value out of being seen twice, once for sure, and then if you're in a rural place, you see them once every 3 months, right? But more times than not, it's once a month visits. And dialysis units tend to run anywhere from 50 to 100 patients. Large units can exceed 100 patients, running 6 days a week or 2 separate types of shifts, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So it's like an all-day thing when you go there, but it's a totally different genre of nephrology when you go there. And they have like wonderful stories and wonderful living to be done. So it's maintenance.
Yeah.
So inside the office practice, you get your mashup of transplants and cancer and obstructive uropathy and kidney stones, and so all that's inside the office. But there's lots to be done in nephrology, and sometimes people will super specialize, like decide they don't want to do stones, or decide they want to do home therapy like peritoneal dialysis or hemodialysis at home. Transplant people will do that, so you could subspecialize. There's an interventional arm too. So not me, but I was interested at one time. Like I did a year of surgery, and I thought when I did nephrology, I would become an interventional nephrologist. The interventional nephrologists were born in the last 10, 15 years. And what they do is they do angiograms of fistulas, and some of them are surgical, like they'll create fistulas and grafts. So you get your real hands-on-y if you want to do hands-on stuff. Some of those guys will still practice some general nephrology, but most of them are purely procedural, and they get their kind of surgical taste buds wetted by doing the intervention. So they'll be doing like maybe 10, 15 cases a day to make sure that our dialysis patients continue to have working access, or pre-dialysis patients have fistulas maturing or matured before they get on dialysis.
Yeah. A good question from someone who apparently knows what's going on in the world. They said, I would love to hear Dr. Robey talk about the big dialysis chains that have cropped up all over. How is that changing care of patients?
Well, that's not really a new thing, really. And it's kind of been evolving over the last 30 years. And then it kind of stabilized in the last 15 years. So historically, nephrologists would often own their unit and grow that unit and then sell that unit either to another nephrologist or to, a collective, like a small practice or a dialysis chain. I'm practicing now 16 years. And so by the time I was becoming a nephrologist, that was done. Like, no more owning a nephrology dialysis unit, and no more selling it for ultra billion dollars, So
we'll wait for her to dial back in, come back. So Rachel said, slightly off topic, but why is it so hard to get a kidney transplant? Because in this country, we have an opt-in transplant system. We need, in my opinion, to have an opt-out system where when you go and you get your driver's license, you are asked, you are a organ donor. Would you like to opt out? And human psychology tells us that people usually stick with the default. And the default in this country, the answer is no. I do not want to be an organ donor. We need to switch that default to be, yes, I will be an organ donor. And you can always say no. So it's very interesting. My dad was a kidney transplant recipient. He was a type 1 diabetic, was on hemodialysis for a long time. So it's something that I'm really passionate about, is getting more people to be organ donors. But unfortunately, we're not there. What else? You guys have questions for me? What questions do you have for me? Let's see what else is here. Ba-dum-bum-bum. Why do people wear hats and gloves outside of dialysis? I don't know. It's interesting. As a doctor, I would want to give all my organs away. Hopefully after you're dead and not while you're living. What else? Would it be possible to donate organs if you were a combat vet? Probably. How massive are the consequences for people who miss dialysis? Pretty bad, right? All of the poisons, quote unquote poisons, building up in your system. That's why we get dialysis, if you can't pee it out. If your hours don't show up, that means either you didn't stay long enough or you're using the wrong email address. Those are the two options. Our system is really good at keeping track of who comes and who doesn't. You can track your hours going to eshadowing.com and click on the verify hours. Pick the one that you think it's missing, and it should tell you how long you watched and what your quiz score was. So if that's missing, try a different email address and see if it pops up there. Hello, Dr. Robey. Rachel, is there a way to verify total hours? Just request a certificate. It will tell you total hours, Rachel. Hello, we got you back.
Sorry about that. It's kind of funny. Let me see if I can get the video. You get a real flavor for Arizona, because what happened while I was sitting in the car is the phone overheated.
It got too hot. Yes. Yeah. That makes sense.
Go.
So lots of interesting questions.
Yeah, I don't think I can get the video of this. Oh, wait, no, here's the little guy. There we go.
Hello there. All right.
Okay. There, that's right. All right. Don't judge. Yeah. So.
Don't judge.
Then I promise not to blip out again, because it's cooler in here. So.
Nice. Well, hopefully more comfortable for you too.
Left for the day. If anybody wants to know, all the hospitalists have left for the day.
Slackers.
So all the hospitalists have a nice cushy job. I'm just kidding, they're not cushy. Anyway, what I was saying was, so the big dialysis companies bought up all these individual dialysis units, and those people cashed out like probably 3-4 years before I started practicing. And so you won't see that much anymore, except for maybe tiny rural places. But even then, if you're rural, you probably can't get the census up until you start being not rural. And then pretty soon, the big companies come in anyway. But right about the time I joined, you could joint venture with a big company. And so there are those, and then any more of those are kind of going away too, those joint ventures on a one-to-one basis, like one doc, one joint venture, or four docs, one, it's just big companies. Now here lately, there's like health management initiatives. So in my lifetime, and certainly in yours, it's just going to be like massive, almost socialized medicine kind of movements, so that everything's packaged. And so then everything can be bought in packages, right? Because bulk buying is the thing to do. So I think that's happening in every specialty, though, just how to consolidate.
Yeah. Yes, definitely is. So what does a typical day look like for you?
It depends on what day of the week I have. Like day to day, week to week, month to month, my schedule's different. So it's not like on every first Monday or every Monday of every week I do X. You have to kind of get a certain number of office days in, a certain number of hospital days in to kind of support your partners. And then we have dialysis rounds. So I round at 2 units, but they each have 2 shifts. Meaning a Monday, Wednesday, Friday, and a Tuesday, Thursday, Saturday. And each one of those clusters has 2 to 4 shifts. So at least 4 of my days a week are going to be dialysis dedicated. And then I'm also a medical director. So there's a fraction of a day or so that's dedicated to taking care of the QAI for the dialysis unit. But typical days tend to start pretty early because you want to pre-round a little bit, take a look at everything that's going on, get your sickest guys figured out, get your acutes that need dialysis figured out. And then if you have to get to office, get to office. So it can be a pretty good day for what we do and what we make. So it would be like at least 10 hours, sometimes 12, if it's just busy winter. But people tend to not work like every day of the year. It's going to be usually about 20 to 23 days of the month. And then usually call is every 3rd weekend. If you're lucky, every 4th weekend. And that's doable, right? And then you go in and you see your patients. And usually, like if you're doing a hospital day, it's like anywhere from 25 to 35 patients. And then if you're doing an office, it's usually 25 to 28 patients. And then dialysis rounds, typically somewhere between 30 and 50 on a that day shift. So it's busy.
Yeah. Do you feel like you have enough time to see the patients and do what you need to do with them?
I think you don't at first, and then you really start to develop relationships and develop kind of familiarity with things, and you just get what you're doing and you know why you're doing it, so things sort of click faster. And so I think you get acclimated to it, because when I first started, it was kind of funny. I was running around at the time. We were going to multiple hospitals. Like you'd pick up 5 or 8 here, and then you'd pick up another 10 here and 3 there. It was really a pain in the butt, but in a lot of places that's how you get your full census. But even that, running around or going to a big, large hospital, which is more common now because, again, consolidation, you just felt like manic, right? Like you've got old patients, you've got critically ill patients, you've got new consults, you're just going bananas. Well, now we've got EMRs, so that makes it a little bit easier to kind of consolidate data. Because I remember part of the thing that held you up was somebody else had the chart, and you're like waiting for the chart, but now everyone has access to information just via the EMR. And then I remember telling my CEO that I was just exhausted running around, like I'm doing something wrong, and she said, "Oh, have you thought about a little yellow pill?" And I was in no mood to be joking around about amphetamines, but I felt like I really needed an amphetamine. But after about 5 years, and that's kind of the post fellowship, I think, curve for when you start to really pick up enough patient familiarity, enough patient load. Because remember, some part of your hospital census is your office patient. And that familiarity immediately helps you carve off a couple of minutes here and there. But my point is after 5 years, it's pattern recognition, it's clinical judgment, so you get faster. and then you can do things with better judgment faster. So don't worry about nailing it the first 2 years or the first 5 years. That's why most people don't make partner for 2 to 5 years, because you just can't carry your overhead.
Yeah. So here's an interesting question, because I think a lot of people are probably confused about this. What's the difference between urology and nephrology, and what sort of overlap is there?
So initially, I thought about becoming a urologist because I really like to be a doer. And there was plenty of medicine in urology. And if you really wanted to do something heady, you could, like, if you wanted to do stones, or if you wanted to do urological cancers or something like that, then you could really get into both attributes of medicine and surgery. Urology is, I call them the plumbers, and they don't mind being called that, but they're very technical by comparison. We're more like cerebral, and so we're the chemist. And patients will always ask us, "Oh, I've got a kidney doctor," and they'll start explaining to us their urologist. Or they'll go to urologist and be like, "Well, why can't you take care of that?" And they're just like, I don't do that. I don't look at your chemistries that way. And I don't prepare you for dialysis and things like that. And they're certainly not going to be looking at diabetes and high blood pressure and obesity and things like that. So, there's certainly need for both. And we do work together well, because as soon as you're not a surgical patient anymore, you're more than likely a medical patient. And so we'll pick those patients up. Or if we have sometimes it works the other way, like you get a mass or you'll get a stone and they'll come see us. And I'm like, you need a knife and you need a plumber. So go to the surgeon. And then they'll come back afterwards or not at all, because their problem got solved. So, it's complementary. But I think for those that are more handsy, you might like urology better. But that's why I told you about the interventional nephrologist, because they do have an arm of it that can be more technical and more surgical.
Yeah, very interesting. Why don't you guys start lining up? We can get some questions. I'm going to clear out everyone. If you want to ask a question with Dr. Robey, raise your hand. We can bring you on. Let's see, some interesting questions. What's the most satisfying thing that you do?
Oh, so I really like my dialysis patients. It's kind of like an oddball thing, right? But I really like that they transition and they keep living, and they're really kind of cool. Like when you're doing your training, you have a lot of inpatient practice, and in the inpatient practice, you see the sickest. So you're kind of like, ugh, dialysis patients, they're so sick, but that's kind of skewed. Really, the functional outpatients are great.
Yeah. Very cool. Let me mute some people here. The dialysis patients. Awesome. Amy, go ahead and unmute yourself. Ask a question.
Hi, I have a question about the COVID vaccine, and if you have seen how it has affected the kidneys in any way with regard to negative reaction or positive reaction, or what have you seen?
Yeah, so that's a great question. When we were dealing with COVID and when we were dealing with potential treatments, we saw more kidney issues or kidney considerations with the actual disease and the treatment of the actual disease, including the antivirals and the antibodies that we could infuse and stuff. So, the vaccine itself has been, bar none, one of the protective things that we could do for our dialysis patients, because they are in all age groups, right? So they're not 65 and over exclusively, although 60% of them might be. All of our dialysis patients are going to be victims and vulnerable. So I thought initially with the disease that I would literally see dialysis units wiped out, like entire shifts and entire units wiped out. It could have happened that way, but they were actually quite good about being careful with our patients and being very aggressive about masking and sanitizing and quarantining. So we protected them really company, and we still saw quite a bit of loss. Like it was like by comparison, a nuclear bomb going off when you lose 200 patients in 1 year for one problem. So as far as the vaccine is concerned, as soon as our patients could, not just because they were 65 and over, but because they were, because it came out in age brackets rather than in disease brackets. But when they could, we got a huge push to get them all vaccinated. And that push continues because that's about the biggest armor that we can have. As far as people who don't have kidney disease getting the vaccine, we don't see them developing kidney disease or developing things that lead to kidney disease. So I think, again, the vaccine is safe, from a kidney standpoint, and certainly a big game changer for our patients who are vulnerable.
Awesome. Thanks.
Mm-hmm.
Thanks, Amy. Let's talk about the training path to become a nephrologist. We skipped over that.
Yeah, so you do have to do your internal medicine. And of course, you can do pediatrics or you can do adult. And then after you do that, you specialize. So sometime around your second and third year of residency, either in adult medicine or pediatric medicine, you then take your subspecialty, probably spend a little bit more time rotating in that specialty, and then apply for your fellowship, which I hope everyone does because we have lots of slots to fill and jobs to fill once you're out. But it's around the end of your third year that you'll match, and then you'll go for your 2 years of fellowship. If you want to do critical care medicine, you add yet another year. If you want to do interventional nephrology, you would typically add another year, and then practice in that group because now they know you and you're their man, right? So it's kind of like a way of transitioning into your private practice too, part of your training sometimes.
Yeah, great. Alex, unmute. You are muted. Unmute yourself.
Hi, Dr. Robey. How are you?
Oh, I'm good, thank you.
I have a question regards to disability in nephrology, like doctor in nephrology. So I have a physical disability, and I was wondering, what is it like for a person like
That's
me?
a cartoon show.
Okay, so if your disability is physical, I actually don't think that is a barrier at all because we actually had many nephrologists who were still very cranial, kind of scoot around in scooters, and they had other mechanical devices. So, because again, it's not a physical sport, it's a mental sport. It's like playing chess. If you have mental or speech impairment, there are avenues for you to practice nephrology. Because again, it's very cranial. You could do kinds of telemedicine, which are mostly, you could do caption related. Like it would be kind of an interesting job for you any job actually for the hearing impaired, because a lot of that is read, right? So you would be doing medicine that's read, right, or signed. And so then you could type what your answers are and explanations are, and they would read it. And so there's a big market there for hearing impaired. There's lots of things that I think you could definitely still do if you're curious about being a thinker. So I hope you investigate it a little bit more. But I had an attending, and I'm not exactly sure what his medical problem was, but he was immobile. And so he actually had this scooter that he came around in, and he was a pediatric nephrologist, and the kids loved him. I mean, they thought he was a transformer. So, he was fine and well received and super respected his intellect. And then I think compassion's a big thing because we deal with a lot of end-stage renal patients. And so anyone who can relate to their disability and be compassionate is certainly a welcomed member of nephrology.
Nice. Thanks, Alex. Mohammed.
Yeah. Could you hear me?
Yep.
Yep.
Yeah, I was just wondering, based on the protein consumption that most people have nowadays, it's very abundant due to working out. I was wondering, does that play a role in kidney failure? And if it does that allow, more opportunity for nephrologists to, be in the field? More opportunity?
We thought it would. It's kind of one of those things where, yeah, I mean, we thought it would make a bigger disease impact. It does make a bigger conversational impact, but it didn't seem to make a huge impact. It's sort of kind of an interesting fad, right? Like to go high protein. Because I remember the day that bread stopped showing up on the table and olives did. And now it's bread or olives, right? But before it was like, oh no, the pasta place is all closed down and, they only serve olives. And so people were trying to do weight loss via high protein intake. And we had to really tell them there is a possibility of a danger, but not an absolute danger. And we know if you take the extreme guys who are big to begin with and then work out and are weightlifters and bodybuilders, they tend to eat tons of protein, not just to sustain themselves, but to actually build that muscle. Those guys could have a lot of protein spillage. And eventually that could create quite a bit of kidney damage. They're conversely also just have big kidneys. And so maybe it balances out. We're not really quite sure. Like I don't specialize in bodybuilders, but I've had a few and then a few Navy SEAL guys, and they're bizarre. Like their estimated function is almost hyperfiltering. And then they do have protein spillage, but is it a problem yet? I don't know, because they're also very young and super healthy. So those guys, what I mean to share them with you is because those guys represent a very unique group. And so now you take an average person of average build who's eating a high protein meal, but not to build muscle, but to maybe lose weight or because they want to maintain weight loss or something like that. We would expect them to spill some protein too, but we don't see them spill as much protein. And then really the high protein diets that people are subscribing to in America really aren't that high by comparison, right? Like, because they're not that lean. Like, people still have quite a bit of fat on them compared to the bodybuilder who's literally got like no body fat at all, right? So I'm not telling you that you can eat like 100 grams of protein a day. I don't think that that's a good way to balance out a diet, because it's really not, unless you're doing vegetable protein, because really everyone should be a vegan, but no one's going to do it. So if you're eating vegetable protein, by all means, it's just like wonderful, right? And it's thought to be not harmful to the kidney. But if you're doing animal protein, I mean, when in evolution has the human species been purely carnivores? I mean, we just couldn't find enough to hunt, to catch up with that biochemically. So just be careful. I don't think it's a good way of life. You don't need a kidney doctor to tell you that. It might be a part of your life, like some episode where you're trying to lose weight or build muscle, but I don't think it's a sustainable way to live, and I don't think your body would like it, let alone your kidneys. So normally it's 0.6 to 0.8 grams per kilo per day. Unless you're sick or immune compromised or on dialysis, we might push it to 1.2 grams per kilo per day. But that's kind of like, if you do the math, it's like, oh, I'm supposed to only eat 40 grams. I mean, I had that for lunch, so it's not really, I mean, Americans don't do it, because really you'd have to be a flexitarian or a vegetarian to really come down to 30, 40 grams of protein a day.
Oh, thanks so much.
Yeah.
Good question, Mohammed.
Now I'm hungry.
I know, I'm starving. It's really interesting because this whole bodybuilding phase and overconsumption of protein is still relatively new in society, right? It's maybe 50, 60 years old. And so there's probably, I mean, I'm sure there's some data on there, but there's, in the grand scheme of things, like, there's still a lot of research to be done on the young 20-year-old who started heavy bodybuilding in his 20s in 1970 or 80 is now getting to a point where it's like, hey, let's study these people and see what their kidneys look like.
So I actually have this guy, and he is a prior bodybuilder, and he's like 91 now.
Mm-hmm.
Oh, did I cut out?
Nope, you're there.
Are you there? Okay. Anyway,
Yep.
so this guy's 91 and he does have some kidney issues, but I mean, you're 91, like some of that's going to be credited to your age, but he's really actually quite fit otherwise. So there was something about, you know, the muscle mass that he obtained, the bone structure that he obtained, and just the general well-being, the approach to food and fitness that he obtained that kind of counterbalanced at some point. Like he kind of hit the optimal combination, and so he looks fantastic, you know, and he's very independent and stuff. So for whatever potential contributing thing that he did, he countered it.
That's great. Tiffany, unmute, say hello.
Hello, thank you. I had a few questions. For one, going back to one question that was asked about the difference between nephrologists and urologists. I was thinking like urologists, they're the ones who are going to look at the fluid outtake and intake and kind of keep track of those. And nephrologists, I always thought of more so as like you were saying, like the chemical part of things or the electrolytes and what's building up and things like that. What exactly is the difference between the two?
Oh, sorry. So urologists are truly like plumbers. I mean, they go in as mechanics to come and fix obstructions and do surgical resections. And if there, you know, there's a kidney cancer or bladder cancer or prostate cancer, they'll take care of that. If there's a stone, they'll remove that. Some of them eventually want to not do so many procedures and they'll do things like stone analysis. But for the most part, they're not really looking at the biochemistries that well, and they're not interested at all in your post kidney failure life. So we're more chemical, more biology than they are. They're more anatomy driven. As far as like fluid volume management, we call ins and outs. That tends to be, unless you have a plumbing problem, like something's obstructing you, that tends to be a chemist's problem, right? To match up your ins and outs.
Okay, so then urologists, if you have something structurally wrong, then the urologist. If you have anything else going on affecting the kidneys, nephrologist.
Yeah, so the reason why they end up dancing together is because you fix anything structural, you might end up with something chemical that's changed, right? So say you have to do a nephrectomy. Well, now you've got 50% less kidney mass, and so you might have chronic kidney disease. Say you have obstruction that's chronic, you might have lost that kidney. Say you have cancer, whether it be bladder cancer or prostate cancer or something, and there's some obstructive element, then it becomes a trickle down backflow issue, right? It's a great question because a lot of patients will come in and say, I don't have any kidney problems. And I'm thinking, how do you know? You know, did you look at your labs and do you know what they mean? But they're saying, I pee fine, I pee a lot. I like the color of my pee. And you're like, yes, that's certainly important that you pee, certainly foamy or not bloody. But in the end, even if you pee, you might not clean and balance. And that's when your chemist has to really look at your blood work, right? And then interestingly enough, this is a little good tidbit for you guys. You'll love this because I always get surprised that more people don't know it. A majority of dialysis patients don't pee. You know, they have kidney failure, so they don't make urine. However, there's a few patients that still pee some or still pee a lot, like a normal amount. And they just come to me and say, oh, I drink what I want and I pee. But anyway, you tell me I have kidney failure. And that's because it can be separated. It's like the pancreas that has exocrine and endocrine function. The kidneys have the ability to balance electrolytes and blood pH separate from the actual filtration, which is surprising once you learn the loop of Henle and everything like that. But it does actually segregate at some point. You need to pee in order to clean, but even if you pee, you may not clean.
Okay. Oh, and one last question. So as far as like piggybacking off of the question that was asked just prior in regards to diets, does your practice or have you heard of practices that also create like info sessions or clinics where patients can come in and ask questions about like, well, I eat this food or these type of vegetables. Is this going to help my kidneys? Is this going to make it worse? Or how can I track the nutrients and stuff that are in here to be able to balance it out? Because like using My Fitness Pal, you're like, okay, well, great. How do I know if that person put in the right info? Like, how do you go about balancing all of that stuff?
It's a little tricky, right? So when people ask about diet, there's actually, in my mind, 3 buckets. There's the diet you have to eat because your kidneys can no longer handle that and sort excess. There's the diet that you have to eat in order to prevent other medical problems that will contribute to kidney disease. And then there's the diet that everybody is chasing to see if it can magically help the kidney. And that's the vegan diet. But, in the end, diet considerations, almost every practice has a arm of nutrition. And that nutritionalist should help hone the patient and their particulars to the diet that will optimize their current and their future. So most practices will have nutritional services available. And in fact, insurance companies and Medicare will cover up to 3 visits a year focusing on nutrition. But most nutritional recommendations are geared towards those 2 buckets. The last bucket, those are studies that are some soft science about eating a vegan diet in order to prevent all medical problems, and then also to prevent protein spillage. So, I'm not quite sure that any nephrologist would just do nutrition. We have lots of nutritional understanding because we do things like preventive medicine and also TPN and stuff like that. But I think there's so much more in nephrology. So if you're interested in just sort of prevention and diet, you could just do it in primary care and lean towards preventing things like diabetes, hypertension, kidney stones, obesity, gout, and then get enough of it. I mean, you could call yourself a, organ specialist, let alone a nephrologist.
Thank you.
I just made
Good
a
question,
job up
Tiffany.
for you. I know.
I just saw that. I'm like, oh, wow, you just create a whole new field. Thank you so much.
Good job. Oh, survey data is historically terrible. How do you trust patients when it comes to that kind of survey data about their food?
Oh, so I asked them, okay, so a lot of them will be like, oh, I should see a nutritionalist, right? And I'll give them the 3 bucket spiel. And then I'll say, here's what I want you to do though. Don't go to anyone and ever say, what should I eat? That's like the worst question ever. You should say, here's what I eat. Okay, here's what I like. Here's what I don't like. So they always have to do like a 3-day food diary. They can do more if they want. I mean, as it turns out, Shaquille O'Neal did a diary for 6 months. Then again, he has 10 chefs and whatever. But this guy really honed kind of what made him feel good and what he liked and what he didn't like. And then he could really pick apart whether or not something was good for him or he had a substitute available. Because diets these days are very diverse, and we combine so much cultural food into stuff. So if you go to a nutritionist and say, what should I eat? I want a menu. You're going to box out a lot of foods that you prefer and a lot of cultural foods that are not accounted for, but don't have any problems. I mean, those fruits and vegetables inside those foods are fine.
Yeah. Anish, before we get to your question, Hong has a great question here. How do you balance something like chemotherapy? If a patient is on chemotherapy, which as a nephrologist you can see is ruining their kidneys, but they need the chemotherapy for cancer, how do you balance that?
Well, I mean, that's a great question that definitely speaks to collaboration and then also just give and take. First of all, you got to think about medicine as not all or nothing. There are no absolutes. And you have to become a good clinician to decide value because your clinical discernment is translated into your advice to your patient about value. And value has many variables, age, quality of life, prognosis, possibilities, other comorbidities. So it's not easy to just blanket statement, which one comes first. It's got to appeal to the patient, but also it's got to take into account who's going to be the better outcome. So we'll have patients who fight cancer end up on dialysis. And to them, that's a win because they're alive and the cancer was the thing that was killing them. And we can keep them alive on dialysis. And then some patients who really have so many other medical problems that kidney failure, it complicates their life because they actually have advanced stage cancer. They weren't really responding to the chemo anyway. And being on dialysis would actually be so cumbersome in their weakened state and in their complicated life. I don't know. Did you get any of that? Because it was actually pretty good. Like,
it was very good. We just lost the last like 10 or 15 seconds.
Oh, okay. Well, that's why I was encouraging you to either become a nephrologist or oncologist, because really those decisions, if you're already asking how to make them, you'd be a great guy to make them sometime, but you just have to position yourself into one of those very critical roles.
Nice. All right, Anish, last question.
Hello. So I've got one question. So what are the most common causes of kidney disease that you see?
Okay. So, it's a little trick question. Age is usually the most common, but diabetes is thought to be the most common since it's such a systemic problem. And then obesity is kind of riding the heels there. Vascular disease, which contributes to stroke and heart disease and therefore heart failure, can also contribute, but it tends to be diabetes because of obesity, and then as they age, they're going to have it. So more importantly, Medicare.
Uh-oh, we lost you again. There's some bug there. I lost you again. There's some bug where if she gets paged on her phone, her audio dies. But now we know the solution. All right, we'll get you off of here in 2 seconds, Dr. Robey.
Yeah, I'm sorry.
That's okay.
Yeah. Anyway, I'll just finish. It's been kind of like spits and sputters. I apologize. You guys are a lot of fun to hang out with. But the Medicare data says that it's really age related. So that's why Medicare cares about our patients and how much we cost, because we've decided in America to provide this service, but 65 and over is our target audience, right? So we suck up a lot of Medicare dollars. So it's getting old. That does it to us, but hey, it's great to be old.
Lay off the Motrin.
Yeah. Just don't do it.
Don't do it. Awesome. Thanks, Anish. Well, Dr. Robey, I appreciate your time. Spits and sputters aside, it was a great conversation. Students loved hearing about everything you were talking about. So I appreciate you. I appreciate your time.
Yeah, I'm sorry it kind of spun out this way. I know you wish it was a little bit more, but then it wouldn't be realistic like that.
Yeah. This is the life of a doctor. Hanging out in the car, overheating, phone dying because of the heat. This is what you do.
People calling you while you're trying to do something else constantly. So
that's what you do. Well,
all right.
Thank you so much.
I appreciate all the people that tuned in. I think it's exciting for them to think about what they could do and might do and who they'll join when they do it. We are kind of nerdy. We tend to be eccentric people, but we're well thought of. And
here's the question. Who's nerdier, neurologists or nephrologists?
You would think that the neurologists are nerdier, but no, we completely geek out on little electrolytes and little nuances and a little electrolyte. So I think it just gets to be, even we kind of get sick of hearing ourselves, but
Awesome. Well, have a wonderful night. Go take care of your patients.
Thank you. Take care.
Thank you, everyone. Bye.
Yep. Bye-bye.